Welcome to the 12 and 15 lead application in EMS class. This presentation was adapted from the multi-lead medic presentation by Bob Page. Lead acquisition should be a priority in any suspected cardiac call. Here is a comparison of two EMS agencies that demonstrates the difference in priority of 12 lead acquisitions. The time difference to the first 12 lead was over 11 minutes. Both of these services are in the same city, going to the same hospital, with the same ETA and similar patient presentations. The second summary shows only a 76-second 12 lead time that was made possible because the agency did a 12 lead first, whereas the other service ran up to four lead rhythm strips before they even ran a 12 lead. 12 leads should be done at the patient's bedside, not waiting until they get into the truck, and certainly not waiting to do it en route. This is a case of a 53-year-old woman with diabetes that asked for a blood sugar check because she felt goofy earlier and thought her glucometer was wrong. The crew agreed to do this for her. Her blood glucose level was 110. She was relieved because she thought her machine was wrong. The paramedic suggested that they check her out with an EKG, and the woman agreed. Here is her initial lead 2 rhythm strip. Looks pretty normal, correct? As you can see, this patient had a massive anterior-septal STEMI with ST elevation in V2, V3, and V4. This shows that in lead 2, you've got no clue. You cannot triage anything with a 3-lead strip, so putting a patient on the monitor is useless and a waste of time. This practice needs to change in favor of a more comprehensive triage method using a 12-lead EKG. This patient was flown to the cardiac cath lab hospital where stents were placed and the patient did well and was released home a few days later. Remember, this patient did not complain of chest pain. However, a sick diabetic is always sicker than they appear. This prompted the paramedic to do a 12-lead. The use of 12 leads should not be limited to those in chest pain, as many patients would not qualify. Diabetes, women, and the elderly frequently have atypical presentations, that is, without chest pain. In 1975 study, the lead placement for a diagnostic 12 lead was defined. It stated that limb leads go on the limbs. That is, anywhere on the limbs as long as you are off the shoulders and below the inguinal ligament, where your legs attach to your body. Most modern 12-lead machines have the lead location stamped on the electrodes. The study gave 2 reasons the limb leads should go on the limbs: angle and amplitude. The angle that the limb leads see the heart from is altered with abdominal or thoracic limb lead placement. The amplitude is also skewed as the limb leads are augmented to make them bigger since they are on the limbs. Taking the limb leads off the limbs can lead to over-augmentation. This can lead to false positives, meaning exaggerated ST segments and size of the ECG, making the 12-lead non-diagnostic. The RA or white electrode means right arm. The LA or black electrode means left arm. The LL or red electrode means left leg. And finally, the RL or green electrode means right leg. So why do so many people put the electrodes on the chest? This is an example of another paradigm, or the way we've always done it. In all fairness, the leads were moved into the chest to reduce artifact in the hospital setting where remote monitoring is allowed. However, by placing the electrodes on the chest, you can only monitor the rhythm. In order to see the patient for access, Hemi blocks, bundle branch blocks, and STEMI recognition, you must have the leads on the limbs. If artifact is a problem, have the patient lie still while you're doing a 12 lead. If their hands are shaking, hold their hands while acquiring the 12 lead. If they are too sweaty, hold the electrodes on with your fingers. It does not superimpose your heart rhythm onto their rhythm. The 12-lead ECG only uses 10 electrodes. With the limb leads, 4 leads give you 6 views. They are leads 1, 2, 3, the standard bipolar limb leads, and the augmented unipolar limb leads, AVF, AVL, and AVR. The 12-lead adds the precordial leads, also known as the V or voltage leads. These leads are to be meticulously placed based on topographical anatomical location, and as little as 2 centimeters of deviation can affect the diagnosis. V1 is 4th intercostal space, right side of the sternum. V2 is 4th intercostal space, left side of the sternum. V3 is between V4 and V2, so it has to be placed after V2 and V4 are already in place. V4 is 5th intercostal space, mid-clavicular line. V5 is 5th intercostal space, anterior axillary line. V6 is the 5th intercostal space, mid-axillary line. V4, V5, and V6 should all be in a straight line. Before reading the 12-lead, it should be validated. If the limb leads are off the limbs, then the 12-lead is invalid. First, look at lead 1. If the P, QRS complex, and T wave are all upside down, this is global negativity, meaning the upper limb leads are switched. In the precordial leads, or V leads, we look for R wave progression to confirm proper lead placement. Notice how the size of the R wave increases in size until between leads V3 and V4, the QRS goes from one that is negative to one that is positive. Poor R wave progression can occur when the wires are misplaced on the wrong side, like V2 on V4, for example. If you see poor R wave progression, look to see if the wires are in the right location. If they are, then this could indicate pathology. Leads 1, 2, and 3 are the bipolar limb leads. They are augmented so they make things look bigger. Leads AVR, AVF, and AVL are augmented limb leads as well. All limb leads must go on the limbs for this reason. V1 through V6 are precordial leads that are unipolar, so no augmentation is necessary. The voltmeter function measures the intervals such as PR, QS, and QT. These numbers are, as a rule, fact and accurate. It also calculates the axis that is also accurate as long as the limb leads are on the limbs. The machine's interpretation can be right, wrong, or deadly wrong. This means that we have to learn how to read a 12-lead so we can see when a machine's interpretation makes no sense or could be wrong. The 15-lead ECG. The importance of running a 12-lead ECG early to triage for STEMI cannot be overstated. Unfortunately, the 12-lead ECG has a notorious lack of sensitivity. That is, only 50% of all heart attacks will show STEMI on the 12-lead. This is in a large part due to the fact that the standard 12-lead does not look at the entire heart. It only looks at the inferior, septal, anterior, and lateral sides of the heart. This is why we should run a 15-lead ECG. A study published on the Annals of Emergency Medicine first documented the benefit of the 15-lead ECG and defined what it is and how to use it. A 15-lead ECG should be performed on all patients with an inferior wall MI, a normal 12-lead ECG, and those with a strong suspicion of having a posterior or right ventricular involvement. A 15-lead looks at two areas of the heart not seen by the 12-lead. The posterior wall, which is V8 and V9 of the left ventricle, and the right ventricle, V4R. The standard 12-lead machine only have 10 wires, so there are not enough wires to run a 15-lead in one pass. It will be necessary to run a second 12-lead to capture the last 3 leads. Running the 15 lead only takes 20 seconds to do. Run the first 12 lead as always. Unsnap wires for V4, V5, and V6 and leave the others where they are. Place V4 on V4R. This looks at the right ventricle. Place V5 on V8 and V6 for V9. V4R is the fifth intercostal space, midclavicular line, right side, the same as V4 on the left. V8 is the fifth intercostal space, midscapular, and V9 is the fifth intercostal space between V8 and the spine. Run the 12 lead a second time, which is now a 15 lead. Once you acquire the 15 lead, it is very important to immediately relabel the leads for V4, V5, and V6 as V4R, V8, and V9. If you fail to relabel them, then the second 12 lead will be dramatically different from the first one in those three leads. 12 lead number 1 shows V4, V5, and V6, and a 15 lead relabeled shows V4R, V8, and V9. What do you look for on a 15 lead? The purpose of running a 15 lead is to increase the sensitivity of STEMI recognition. So we are looking for ST segment elevation. ST elevation in lead V4R alone is diagnostic for right ventricular infarction. ST elevations in leads 8 and 9 are diagnostic for posterior wall myocardial infarction. Here is an example of where they did V7, V8, and V9. While there are reciprocal ST depression changes in V1 through V3, it is neither specific nor sensitive for posterior wall MIs. Spend the extra 20 seconds and confirm it with a 15 lead. The importance of a 15 lead ECG. You should run a 15 lead on all non-diagnostic or clean 12 leads. Using V8 and V9 can locate isolated posterior MIs by looking directly at the posterior wall of the heart. V4R looks directly at the right ventricular infarctions. 50% of inferior wall MIs, which is ST elevations in leads 2, 3, and AVF, have right ventricular involvement. Right ventricular infarction is a preload problem and could cause dramatic hypotension, even death with nitroglycerin. The American Heart Association calls right ventricular infarction a contraindication for nitrates and morphine. In the case of inferior wall MI, or normal 12 leads, do not give nitro or morphine without first running a 15 lead to look for right ventricular infarction. Since this is a huge preload problem, the body could be in compensated shock due to reduced filling. Acute management for some providers includes rapid infusion of normal saline, as much as 1 to 2 liters or more. This increases right ventricular filling, thus recruiting the Starling forces, increasing the contractility. Always assess and reevaluate your patient and follow your local protocols. Check with your medical authority to see what they recommend for right ventricular infarction. This may be different from the standard chest pain care. Some services allow for nitro drips or infusions at a start rate of 5 micrograms per minute to allow the benefits of nitroglycerin without the drop in pressure with higher doses. Nitro spray or tablets are absorbed at the rate of 200 micrograms per minute. Taking only 20 seconds at a cost of 20 cents to run, and with the benefits of an 86% increase in sensitivity for posterior wall MI and detecting right ventricular MIs, preventing a potentially deadly drug error with nitrates, why would anyone not run a 15 lead? We will now move on to rapid axis determination. Axis is the predominant direction of the flow of the impulses in the heart. Axis can be significant in pre-hospital care. It can help you diagnose ventricle tachycardias. It can also be used to see chamber enlargement or hypertrophy. It can also be used to diagnose Hemi blocks. Finally, it can help you identify which patients are at high risk for a complete heart block or for becoming hemodynamically unstable. The basic concept of electricity in the ECG signal is that an electrical current moving toward the positive electrode causes a positive deflection, while the electrical current moving away from the positive electrode causes a negative deflection. The stronger the current, the stronger the deflection. Although electricity moves in many different directions as it depolarizes in the heart, it moves in one general direction. This is called the axis. It would be nice to be able to see an arrow on the chest of a patient that indicates the direction of travel. Well, we may not be able to see the direction, but we can track it. Using the basic concept of electrical signals, we can place 3 leads around the heart. Limb leads 1, 2, and 3 are shown here. The position represents the relative location of the positive electrode in each of those 3 leads. Each location will show us by the net deflection of the QRS complex whether the impulse is coming towards or going away from its respective location. In this example, lead 1 is on the left side of the heart and it looks at the entire left side. So if the impulse is traveling towards the left side, it will show a positive or up deflection. Lead 2 sees the impulse coming straight at it, so it will also show a positive or up deflection as well. Lead 3 still shows it coming in its general direction, so we would see a positive or up deflection as well. This finding, up in leads 1, 2, and 3, are considered a normal finding in adults. This slide is just showing the basic quadrants of axis deviation. 0 to positive 90 is normal. Positive 90 to 180 is right axis deviation. 0 to negative 90 is left axis deviation. Negative 90 to 180 is either called the indeterminate axis or its extreme right axis. This chart shows you how to quickly determine the axis. First, run leads 1, 2, and 3. Then you determine the mean QRS deflection in each lead, which is, are they up or down? Finally, you compare to the chart and it gives you an instant axis. Here are the normal axis variants. The first picture here shows up, up, and up in leads 1, 2, and 3. That is a normal axis. The second picture shows an up, a split, and a down. That means it's a physiological left axis and not harmful. Here we have a left pathological axis. The strip has up, down, and down in leads 1, 2, and 3. Left axis deviation is often associated with hypertension, valvular heart disease, and anterior Hemi blocks. Here we have right axis deviation. The strip has down, up, up in leads 1, 2, and 3. Right axis deviation is associated with COPD, pulmonary hypertension, and posterior Hemi blocks. If you have a machine that gives you the axis information recognized as the R-axis or the QRS axis that is expressed as a number, use it. Simply look at the number and compare it to the range of axis found on your rapid axis and Hemi block chart, and you can call the axis that way. You will find this speeds up your axis assessment, especially when there is a wide complex tachycardia, when up and down are not always so clear. A Hemi block is a block of one of the fascicles of the left bundle branch. A Hemi block is a diagnosis that's made on an ECG. Hemi blocks are significant because they can be an indicator of conduction risks and severity of acute conditions such as an acute MI. A Hemi block in the setting of an AMI means there's a 4 times greater mortality. Anterior Hemi blocks are associated with pathological left axis deviation. They can also have a small Q wave in lead 1 and a small R wave in lead 3. It is a common block that is associated with an increased mortality rate of up to 4 times more than an AMI without an anterior Hemi block. A Hemi block or other conduction system problem when associated with the signs and symptoms of an AMI can indicate a proximal occlusion of a coronary artery. The hemifascicles get their blood supply from a proximal artery branch. Therefore, we assume a proximal occlusion has occurred. Mortality rate is higher because with a proximal occlusion, the risk of lethal arrhythmias is higher due to a larger area of ischemia. Posterior hemiblocks are associated with right axis deviation. They can also have a small R wave in lead 1 and a small Q wave in lead 3. They have a very high mortality rate when seen with signs and symptoms of AMI, which is about 70%. Having 2 coronary arteries with a posterior hemiblock is a rare occurrence. The most common cause of right axis is a right ventricular hypertrophy. Remember to use the chart to help you determine axis. People can live just fine and be asymptomatic with a hemiblock or axis deviation. It becomes relevant only when accompanied by the signs and symptoms of an acute AMI. Remember, pay attention to your patient while keeping the ECG findings in the back of your mind. A right axis deviation is normal finding in children, but a right axis deviation in adults is always pathological. Besides a posterior hemiblock, it can also be indicative of pulmonary embolism and right-sided heart failure or cor pulmonale. Cor pulmonale causes right ventricular hypertrophy. A bundle branch block is a block of either the right or left bundle branch system. A working knowledge of the bundle branch blocks will help the paramedic determine 1. Who's at risk for hemodynamic compromise, and 2. Who's at risk for a complete heart block. The bundle branch system is made up of 2 main branches, right and left. The left bundle branch system is further divided into 2 hemifascicles, the anterior and the posterior. The purpose of the bundle branch system is to facilitate the entire ventricular mass to get the impulse to contract at the same time. This causes the ventricles to be synced and both firing at the same time. Being synced is very important to the cardiac output. In the cases of a bundle branch block, the ventricles are not in sync. The preload could be reduced due to inadequate filling time. If the ventricles take prolonged time to contract, then the force of the contraction will also be reduced. A block of one of the fascicles of the bundle branch system can be caused by myocardial infarction, either old or new, congenital defects, or by ischemic tissue. In a few cases, people have acquired a bundle branch block secondary to a procedure known as RF or radiofrequency ablation. This procedure is performed to destroy cells which happen to be part of the bundle branch that cause ectopy or dangerous rhythms such as V-tach. Some bundle branch blocks only occur during fast heart rates and can have defined start and stop rates. Nonetheless, a bundle branch block represents an increased severity risk for complete heart block, hemodynamic compromise, and of course sudden death when associated with an MI due to the proximal occlusion of the left anterior descending coronary artery. As the impulse coming from the AV node travels down the bundles, it reaches the tissue that is blocked on one side. The impulse stops on that side. The other side proceeds to depolarize as normal. The wave of polarization eventually works its way across to the block side, causing a delayed depolarization. Then at point number 2, as you might have guessed, the ventricles contract out of sync. The more diseased the muscle, the longer it will take to completely depolarize the heart. If the total time to depolarize the ventricles are longer than 120 milliseconds, or 0.12 seconds, then the criteria is met for a bundle branch block. If the QRS duration is greater than 120 milliseconds, or 3 little boxes, then at least a bundle branch block exists. The ventricles, being out of sync, have reduced preload. If the QRS is greater than 120 milliseconds, then the ejection fraction is 50% at the most. Ejection fraction is the volume percent of the blood the heart can pump out. Healthy people at rest and awake have an ejection fraction between 60 and 75%. This results from the reduced contractility because it takes so much time to depolarize. The contraction is also slow and weak. The QRS duration, less than 120 milliseconds, can also have a poor ejection fraction. In this case, careful assessment of the patient with the stethoscope can assist here. Crackles in the posterior or lateral bases almost always indicates pulmonary edema, effusion, or poor ejection fraction. Heart sounds such as S3 or S4 mean ejection fraction less than 30%. Before you give a med, other than oxygen, make sure you determine the presence or absence of a bundle branch block. If the QRS is wider than 120 milliseconds and you are going to give a vasoactive drug such as nitroglycerin, remember, before giving nitro, always check the lung fields for crackles, especially the posterior lobes. Listen to the heart sounds such as heart tones S3 and S4. Always have a Plan D ready. Plan D is actually the drug dopamine or intropin. The dose for contractility support is 5 micrograms per kilogram per minute, then titrated. Since the left side has 2 fascicles and the right side just has 1, a left bundle branch block has a higher mortality rate. It is important for the acute care providers to understand bundle branch blocks and be able to rapidly identify and differentiate left from right. The methods presented in this session may seem ridiculously simple, but they are very accurate. We should all be familiar with the turn signal theory for bundle branch blocks. This criterion is incredibly accurate and has been proven in studies. Its method is non-traditional and has nothing to do with medicine. In using this criteria, there are 2 main rules. Number 1, it must be a supraventricular QRS complex greater than 0.12 seconds wide, or 120 milliseconds. Number 2, you must use lead V1 for this theory to work. Step 1, find the J point and circle it. Step 2, draw a line into the QRS complex until halfway through the terminal wave, and then down or up depending on the complex. Don't cross over any lines with yours. Number 3, shade in the arrow that this line makes. If the arrow points up, it's a right bundle branch block. If the arrow points down, it's a left bundle branch block. 2 great facts to keep in mind. An actual QRS complex in lead V1 that is greater than 120 milliseconds is a left bundle branch block diagnostic. An actual RSR prime complex in lead V1 that is greater than 120 milliseconds is a right bundle branch block diagnostic. These are important facts to know because a bundle branch block that occurs with a fast heart rate is known as a rate-dependent bundle branch block. It looks just like VT, but it is not. That is why we do not assume everything that is wide and fast is ventricle tachycardia. Here we have a 12 lead with a wide QRS in V1. We see that it's larger than 3 little boxes. We find the J point, draw a line, and color it in. And it shows us a left turn signal. Here we have a 12 lead with a wide QRS in V1. We see that it's larger than 3 little boxes. Find the J point, draw a line, and color it in. And it's a right turn signal. Bundle branches are living, breathing cells of the cardiac conduction system. They don't hurt, they just won't work if damaged. Being synced is necessary for crisp contractions and good cardiac output. A bundle branch block can cause a reduction in preload and contractility. A very wide QRS, greater than 170 milliseconds, means reduced ejection fraction below 50%. You can't accurately or consistently call a left bundle branch block or a right bundle branch block from a lead 2 strip. Bundle branch block means at least 25% greater mortality. A left bundle branch block has a 50% mortality. Like Hemi blocks, people can live asymptomatic with bundle branch blocks. A bundle branch block usually affects their lifestyle more, however. Due to the hemodynamic effects as mentioned earlier, the bundle branch block will not allow much strenuous activity before putting the patient supine. As always, pay attention to your patient and keep this information in the back of your mind as you consider the treatment options and possible problems. Don't look for an AMI by standard ST segment elevation with a left bundle branch block. Why? You may recall that in bundle branch block, the ventricles are firing out of sync. In a left bundle branch block, the right bundle branch depolarizes first, followed by the left bundle branch. By the time the left bundle branch completes depolarization, the right bundle branch has started repolarization. This is evidenced on the ECG as a T wave. This being the case, there was never a time in the cardiac cycle where there was not electrical activity going on. Therefore, the ECG did not have a chance to return to baseline and record an isoelectric ST segment. Thus, in a left bundle branch block, the late depolarization and repolarization distorts the ST segment into appearing elevated. Therefore, most clinicians consider a left bundle branch block to be a non-diagnostic ECG for AMI unless, of course, they have a previous one to compare it to. This is always a major benefit. Which of your patients is at risk for a complete heart block? You have all the information available by running a 12-lead ECG. This is an important fact to know since some commonly used drugs can be contraindicated in the presence of severe degrees of intraventricular heart block. A severe degree when you have 2 or more blocks listed at once. Here's a list of those considered to be a severe degree of block. You need to prepare for a symptomatic patient with a bifascicular block. This type of patient is much sicker than an uncomplicated MI. They may go into complete heart block suddenly and without warning. Their blood pressure may drop precipitously, especially if the QRS is greater than 170 milliseconds. If so, remember the 3 things to do before you give nitro and ask how much they weigh. They may just go into VFib or VTAC without warning. Antiarrhythmic drugs are contraindicated in cases of PVCs or transient tachyarrhythmias, so treat the cause of the arrhythmia. In patients with signs and symptoms of an MI and all unstable patients, place quick combo or multifunction pads on the patient. Be prepared to pace the patient. Be prepared to defibrillate the patient. Some patients may tolerate this condition well until they get up to go do something. Their heart cannot fill the request for extra output due to the compromised conduction system. The 2000 guidelines of the American Heart Association put an end to unknown origin wide complex tachycardia by calling for a 12-lead ECG to attempt to diagnose the specific rhythm. In other words, they strongly discourage a give a drug and see what happens approach. The 12-lead ECG is 96% diagnostic for VT identification. There have been several criteria used. In this section, I will present the Key 3 Plus criteria. The combination of these criteria, when used for stable, wide complex tachycardia, the following clues can help you make the right call and give the right medications if needed. You may ask, why even mess with a 12 lead? Can't we see it most of the time in a lead 2? Dr. Marriott has a compelling study that demonstrated that lead 2's diagnostic accuracy for VTAC as being only 34%. That means when faced with a decision about a wide complex rhythm, you would guess wrong 66% of the time. Here are the most common pitfalls in diagnosing wide complex tachycardias. There is now more benefit and less risk in knowing the arrhythmia. The patient will further benefit from the 12 lead because you may be the only one to see this arrhythmia. If you have a 12 lead, it will help the cardiologist determine the origin of the arrhythmia. Since ventricular tachycardia is a life-threatening arrhythmia, the Key 3 Plus criteria presented are designed to aid the acute care provider in the rapid confirmation of the presence of ventricular tachycardia. Be prepared, as the machine cannot read VT. Therefore, it will print all kinds of messages, including deadly wrong messages or conflicting messages. Here is one from a modern 12-lead machine. It writes probable VT and a left bundle branch block. You cannot have both of these conditions. If the patient presents in a wide complex tachycardia, especially one faster than 150 beats per minute, then use the Key 3 Plus criteria before you do anything else. The reason is simple. If the patient is in VTAC, then you must treat it now. If the patient is in a ventricular arrhythmia, then nothing else can be read on the 12 lead. No Hemi block, no bundle branch block, no ST elevation, nothing. This also applies to the patient who has any type of ventricular-based rhythms: paced ventricular, idioventricular, accelerated idioventricular, and even a third-degree heart block with ventricle escape focus. Key 1 is, if they have an extreme right axis deviation and an upright V1, then you have ventricular tachycardia. Key 2 is that if you have an upright complex in V1, and it looks like any one of these morphologies, number 1, taller left peak than right, big mountain, little mountain. Number 2, single upright peak, steeple sign. Number 3, single peak with a slur or the fireman's hat. Lead MCL1 or V1 morphology has a 94% accuracy for ventricular tachycardia if it looks like one of these examples. If they look like this in a wide complex tachycardia, treat for ventricular tachycardia. If it does not meet these criteria, try the third criteria in V6. Here is Key 3. Any negative deflection in V6, when you get to this point, is ventricular tachycardia. This assumption is made based on the fact that the lead V6 is located on the left lower part of the heart, and an impulse going away from V6 more likely starts in the ventricles. Rare cases show a fat Q wave in a biphasic complex. Another way to use V6 is in conjunction with V1. If you can get both on the screen together, then it's easy to monitor them. In normal conduction, V1 is usually negative and V6 is a positive deflection. A change to the wide complex tachycardia that sees V1 turn up and V6 turn down means ventricular tachycardia. The first new criterion for wide complex tachycardia in almost 40 years has been published. It uses lead AVR, the forgotten lead, but not anymore. The R wave in AVR is 98% accurate for ventricular tachycardia. Not all ventricular tachycardia will have this, but if they do, they are in ventricular tachycardia. What if you still don't know after the Key 3 Plus criteria? Well, the chances are it could also be a rate-dependent bundle branch block, in which case the safe play is to give adenosine first. The 2010 American Heart Association tachycardia guidelines state that stable, wide, and monomorphic tachycardia can get adenosine first, as this will bring out the bundle branch block. Here are some other interesting notes about ventricular tachycardia that may be helpful. Ventricular tachycardia, unless drug-induced, is usually very regular. Irregularly irregular rhythms are probably atrial fibrillation. Ask 2 questions. Have you had an MI before? And did you have tachycardia after the MI? If you get a yes to both questions, the odds favor VTAC by 86%. Patients demonstrating positive ECG criteria shown here would reap the greatest benefit from early reperfusion strategies. Every effort should be made to expedite the process. The pathophysiology of acute coronary syndrome can be represented in 12 leads in 3 ways. Ischemia can be seen by looking for new ST depression in 2 contiguous leads and flip T waves. Injury is identified by ST segment elevation in 2 contiguous leads. And infarction can be represented by pathological Q waves. However, Q waves are of little use, present or absent, in the management or diagnosis of an acute event. Here is a system for assessing a 12-lead ECG for infarcts. As we all know, I see all leads, and then it adds RP. I see all leads stands for inferior leads, 2, 3, and AVF, septal leads, V1 and V2, anterior leads, V3 and V4, lateral leads, V5, V6, 1, and AVL. R stands for right ventricle, or V4R, and P is posterior leads, V8 and V9. Here's a handy chart on how to locate the acute MI. Here are some things that could have ST segment elevation but aren't an acute myocardial infarction. Some of these infarct imitators are left bundle branch blocks, pericarditis, and a dissecting thoracic aortic aneurysm. Here's an algorithm to use to help you through the steps shown in this presentation today. At first, doing multi-leads may seem a bit awkward. There may also be those who have never heard of it, or others who give you a hard time about multi-lead things such as lead placement and running extra leads. Remember, however, that is your patient. You always want what's best for your patient. Time does not pass as fast as you might think. Also realize that the methods taught in this course are non-traditional and that there are many ways to get to the correct interpretation. Don't be surprised if others get the same answer in a very different manner. Also, don't be surprised if some don't believe what you have learned. Lead by example.